Hi everyone, I'm Osama here. Today we have an interesting interview with Dr. Peter Ree, who's an orthopedic hand surgeon with a special interest in the upper extremity post-traumatic reconstruction, including the reconstruction in adult and pediatric patients with brain injuries. He's a full professor of orthopedic surgery and currently serving as a program director at Mayo Clinic for the Hand Surgery Fellowship. He is a former active duty and current reserve hand surgeon at the U.S. Air Force. He is passionate for everything outdoors, especially hunting and fishing. Nice to meet you, Mr. Ari.
Very nice to meet you. Thank
Thank you.
you.
Thank you. It's a great honor to have you here. We want to continue our previous interview about managing spasticity patients. Okay, so let me first start with what are the difference between managing patients with spasticity in pediatrics and adult population?
I think the procedures are fairly similar, but in kids, the challenge is as they grow and as the bones get longer, the muscles can sometimes get tighter and tighter and tighter. And so, if there's longitudinal skeletal growth, if you manage spasticity with, let's say, muscle lengthening procedures, it may work good at that moment. But then as they grow, if the muscles don't have the capacity to stretch as much, you could have a lot of recurrences. And so in kids, we try to avoid surgery until we need to do something. And by need to, I'd say when there's like a really, really fixed deformity where we really feel like we have to do something, or if there is enough spasticity that we can treat, we try to do nerve-based procedures to treat the underlying problem and not treat the muscle because that can recur. And then in kids, we also try to intervene um, early before kind of the teenage years because they may it's a lot on their development, especially with confidence at school. If they have deformities and postures, and we try to treat them um, once they get to closer to skeletal maturity, but early enough that it's in a formative time in their schooling and their social life where it's not so stigmatizing.
I see. So it's totally different as compared to the adult setting.
I think your surgical procedures are the same. It's what you use and how you use it and when. I think it's a little bit different with kids.
Okay. So how is the population with the spasticity around, like in the center you are managing?
So my hospital is a large referral center, and so even despite that, there are as many patients that I see that are from local. And I think that's a good illustration of the fact that there's so many patients that have stroke or a subset of patients that are born with cerebral palsy or traumatic brain injury. So just even in your local community, wherever you are, there's tons of patients with strokes that have some sort of disability. And if you just look, they're there. And a lot of surgeons don't treat the spastic upper or lower limbs. So I think there's a very underserved population that we can help tremendously.
I see. But do you usually got those patients like referred from their primary care or from the neurologist, or how did you
Yeah.
get your patients?
So most of my patients either come from referrals, so that's usually neurology, or at my center, it's physical medicine rehabilitation. And then I have patients that, patients and their families are engaged in a lot of support networks at home or online. And a lot of my patients come from the peer-to-peer referrals
I
too.
see. Yeah, that works well also. Yeah. So because the last interview with the Dr. Vaikuntan from Singapore, he said about 20% of the Singapore population having a stroke, which is actually for Singapore scale is quite a big number. So you think for your area also the numbers are quite big?
Yes, the burden of stroke in the United States and the world globally, it's tremendous. And so it's of those patients, a large majority will have some sort of disability because of spasticity or weak or paralyzed muscles. So there's most patients that have stroke that don't recover fully. There's usually something that can be done to improve their quality of life.
I see. So what did you what did make you keen to go and explore this area in nerve surgery?
It was a little serendipity or luck or fate, I guess. I had kind of learned these techniques for traumatic brain injury patients when I was in the military, And I didn't really treat stroke patients, but then my father had a stroke, and early on, in his early recovery, he had quite a bit of spasticity and posturing, and every time I would see him, I'd say, gosh, there's got to be something we can do. So I just researched it and found there are things, but not very many people doing it. And that was really the first time I actually looked at an article or read a book on spasticity. And then from there, when I first started getting a few patients, I had that information and I felt like I could help them. And then from there, it just blossomed.
That's an interesting story. Okay, so moving forward, most of those patients usually require a multidisciplinary team approach, right?
Yes.
So how did you form your team, and how did you collaborate with other disciplines for managing such patients?
I think you're right, because even if you as a surgeon feel like you can help, if you don't have the referral pattern, so you don't have primary referrers, neurologists, physiatrists that trust and believe in what you can do is helpful, you won't get the patients initially. If you don't have the perioperative team that is, because a lot of these patients are sick, they're on anticoagulation, they have other comorbidities. If you don't have the team to safely do surgery, you can have complications. And then afterwards, if you don't have the therapists, occupational and physical therapists that can help with initial hand rehab, or later on just global brain rehabilitation to try to incorporate their arm into their everyday lives, then your surgery will fail. And so I think that's very important, that you do need a multidisciplinary team. And I think the best way that it worked for me was that I just went to those individuals, the primary referrers, and I explained what surgery was, what my philosophy, what my approach was. And then once I gained their trust and they started sending patients, and then eventually they saw those patients come back to them and they could see the benefit. Yeah. Then they believed, they would send me more patients. And then our first few patients, I made sure I communicated with the anesthesia team, their medicine doctors, made sure that they were safe for surgery. And then with rehab, a lot of our therapists didn't know how to do the therapy for these patients. And so it was a partnership. We learned together and we would modify our protocols. And so it was a great partnership. And even now, we've been doing this type of surgery at Mayo for 8 years, and we still continue to evolve.
But did you get any resistance at the start?
A little bit. I did get some resistance because it was mainly from not the hand therapist, but the rehab therapist. Because the rehab therapist, especially for kids with cerebral palsy or patients that they've had it for a long time, they become like their family and they get protective. And so sometimes they feel like surgery may hurt the patient. And so I did have some resistance too, but instead of, I think what surgeons may do, get defensive, I just went to them and said, look, let me answer any questions you may have. I want you to get to know me and know that I'm doing very thoughtful, conscientious surgery. And then once I did that and I gained their trust, it was a good partnership.
That's great. Okay, because I think usually at the start, it's quite hard to push the boundaries.
It is. You got to make sure everyone's willing and everyone's on the same mission and goal.
So, how do you usually assist the patient in the clinic? Like, you have like a team to document, to take videos, or how does it go for them?
Yes, I do have a team. I think it's really important, especially in spasticity, because even if the room temperature is not right, if they get anxious because of your demeanor, if your initial exam maneuvers are aggressive or not, sensitive, I guess, then their tone can really, really get increased. And then your exam may be different than what they normally are like. And so we really try to have a warm environment, we have it in an area of our clinic that's quiet. We have enough room for families so that they feel comfortable that everyone that they want there is there. And then the assessment is very, very slow. It takes a long time because I speak with them, get them relaxed. I first have them move so I can see what they can do, because as soon as I touch them, they start to tense up. And if you tell a patient with spasticity, relax, just relax your arm, they do the opposite. And so I think it takes time to know what your strengths are in your exam, but just to do a very systematic exam document very clearly. And I don't think you can make your surgical plan off of just one visit. You know, I do at least 2 or 3 visits before I say, here's my plan. And it's amazing when I first do my assessment on first time, second time, third time, things change in between. And it's not that the patient has really changed too much, but just how they present that day. So I can get a good assessment over time, and then I can come up with a good surgical plan. So the assessment is very important.
Yeah, I think with subsequent visit, I think when the patient gets more comfortable and trustability, then it's easier for you to put your plan right.
Absolutely.
How do you deal with the patient expectations, and especially also you treat pediatrics? So I'm sure also the parents' expectations are even quite higher.
Yes, you're absolutely right. Parents have higher expectations. I think that although parents of children are much easier, I think, and I learned that the hard way because a lot of adult patients can make their own medical decisions. And so they may come to the clinic by themselves. And a lot of patients may have receptive aphasia. So they hear, but they don't process and retain. And so I had a patient I recall that I spent a lot of time talking to them, and they seem like they were understanding. And I'm very clear and I give very realistic expectations. You know, my philosophy is to undersell, over deliver. And so, you know, I say it's never going to be a normal arm, but here's what in the best case scenario, this is what I think you're going to achieve. And let's try to achieve that. That's our goal, but it's not going to be normal. And in kids, the parents understand, even though they have high expectations, I temper that and I tell them, this is what we can achieve. This is only what's possible. You know, are you okay with that? And then they understand. But in adults that are usually by themselves or they're with a caretaker, it seems like they forget. And so in some patients, we actually videotape that conversation so that when they come back, a lot of times they'll say, well, I thought I could do more. And I say, no, this is all I am very happy with where we are right now. I think that we achieved what I was hoping for. And that's where preoperative video is very important too, because I think that patients in the early phase are very happy. So 3 months, 6 months, but at 1 year, 2 year, they kind of forget where they started and they want more. And they say, gosh, if I could just do a little bit more. And sometimes then I'll say, you know, that was never possible. You could never open your hand. You had no volitional control opening your hand. None of my surgical procedure was going to get that back. But we have a hand that's open. Let me show you a video when you first had surgery. And they were like this, you know, and they go, wow, actually just being able to do this that's good. Yeah. Expectation setting is one of the most important things. And then also having a shared decision making. Because a lot of times I'll say, this is all that's possible. Are you okay with that? Because it's a big surgery. And if they say yes, then we agree together.
Yeah, that's great decision making from you. What do you think about the peer-to-peer support or experience, or like, do you have any kind of forms of patient education?
I don't have anything like a formal, like an online like community that I manage or I oversee. Actually, I try to stay out of any type of things like that. But I do think that peer-to-peer support is very important. So if patients don't have that, I just tell them to seek out somewhere online. But with that said, a lot of my patients and families are so grateful when I'm, you know, done with surgery and we've had some good recovery or a good time from surgery. I'll ask them, you know, if, you know, before you had surgery, did you have a lot of questions and concerns and worries? And they say yes. And I'll ask them, you know, I have a lot of patients that may feel that way. Are you okay if anyone in your similar situation wants to talk? Are you okay if I give them your contact information? And almost everyone says absolutely.
Yeah, I think it works well for such a group of patients.
Yes, I think so.
So, how do you foresee the use of contralateral C7 in those group of patients?